Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Today we are bringing you a podcast where we are going to discuss communications difficulties for house surgeons or resident medical officers. My name is Dr. Chow Yen Chen, and I am here with my colleague today, Dr. Sam King. We are both medico-legal advisors with the Medical Protection Society. Today we're very lucky to have as our guest Dr. Ashwina Rao, who is an anaesthetist in Auckland. Ashwina has been an anaesthetist since 2003 and has undergone training in various communication models since 2015. She now runs communications training for doctors, which involve one-to-one and small group training in compassionate accountability, a model for navigating conflict. The Emotional Culture Deck, a game which creates a space for open communication and strengths a wellbeing tool to enhance performance. Hello, Ashwina, and thanks for joining us this morning.
Good morning. Thank you very much for having me.
So today we're going to talk about some communications issues that can arise in all aspects of our work for our resident medical officers or RMOs, colleagues, and consider some practical solutions. So we're going to consider some different scenarios, and we're going to start with this one. So Ashwina, let's say that you're the anaesthetist in emergency theatre and you get a call from a house surgeon looking for some advice. They've been asked to review a patient who has blood pressure of 180 on 90, and the charge nurse has asked them to prescribe some amlodipine, because this is usually what's done in this situation in her experience, and the anaesthetist won't be happy with that blood pressure. The house surgeon hasn't encountered the situation before, so they decided to call you. What would your advice be?
So thanks for sharing this situation. This is actually quite common for us to be called in theatre for patients on the acute list. I think I'd start with saying it's okay if you don't know the answer, because ultimately, as the prescribing doctor, you are accountable for the medications that you prescribe.
Yes.
And so if in doubt, ask help from a trustworthy source. If a house surgeon called me in this situation, I would validate that was the right thing to do.
Yeah, so in this situation, what would you talk them through? Would you suggest a management plan, or would you ask for more information?
I think in general, if somebody's calling me and I'm managing the acute list, I would like them to introduce themselves, their name and their role, and then give a very short reason why they're calling, and then ask me if I have a few minutes to answer a specific question. So if they present the information logically, case history, anything relevant about the admission, reasons for requiring surgery, etc., then it'll make it very easy for me to answer. But say, for example, it's a patient who's young and otherwise fit, who have a fractured forearm on the list awaiting surgery for an ORIS of a fractured forearm, for example. I might tell them to start with the simple things like make sure that the patient has well analgesics, make sure the patient is comfortable, reassure the patient if they're feeling anxious.
Yes.
These will be very simple things, I think, that may help them to manage the sign, which is the blood pressure is high, which is probably just reflecting those things.
If I think about house officers ringing an SMO, I suppose to start with, it's a bit hard for me to remember all those years ago when I was a house officer, but sometimes it can be a little daunting calling an SMO. It's a bit different when you're talking to a registrar. I think that because you're closer in age and station, but when you talk to an SMO, it can be a little daunting because you don't want to come across as being stupid or feeling silly or saying the wrong thing. But from what I'm hearing from you, Ashwina, is that the house officers should be well prepared before they ring you. So they need to know about the patient, the history, what the situation is, what the blood pressure was, and so that they come armed with all of that information, because I can understand that as an SMO, you don't want to have to, you don't want the situation where you're asking questions and they don't know the answers and it's taking more time, and you're
Absolutely.
yeah. So that's a really good idea, isn't it?
Yeah, I think it's really helpful that you said it's really useful if they ask if it's a suitable time to talk to you, because you might be in the middle of doing something and you're not meaning to be rushed or coming across as abrupt, but you're just busy right at that second, and you'd be happy to talk in, say, 5 minutes time. So I think that's useful.
Absolutely. And I will say that even after practicing for 25 years, if I'm calling the cardiologist or any other medical specialist, a GP, I will approach this in exactly the same way. And I will still feel that I want to give that person a sense that I value their time, and that I have a very specific question that I want them to answer. And I think the more clear that any of us can be with that, the better it is for the outcome of the conversation.
Yeah, absolutely. And so, well, let's say that the advice that you've given, which is just check that they're well analgesed and that, give them some reassurance. So that's different to what the charge nurse is looking for. They've suggested amlodipine. Have you got some suggestions for a house surgeon when, the advice that they're going to go back to the sometimes scary charge nurse is a little bit different to what they're looking for?
I can see why it might feel uncomfortable to go back to the nurse with a differing opinion of management. However, I really do believe that both of you will want the best outcome for the patient. So in these situations, it's really best not to have or make any assumptions about how your information will be received. And so I think openness is by far the best approach in this situation. So they could open by saying something like, I was unsure about the rationale for treating Mr. X's blood pressure with new medication. And so I sought advice from the on-call anaesthetist. They had suggested giving analgesia and are okay without giving medication for the blood pressure. How does that sound?
Yeah.
In this situation, the house officers phoned a friend, the SMO, and that carries an awful lot of weight. I don't think a charge nurse is going to go, well, that wasn't a good idea because the house officer's spoken to you. But what if it's a case where a house officer knows what to do, but the charge nurse or the nurse they're talking to disagrees? And I'm sure that happens quite a bit. And if you think about house officers when they come onto the wards, you've got to deal with a lot of different people, a lot of different personalities, people from different professions, and which can be very difficult to negotiate. So how would you suggest a house officer approach the charge nurse in that situation where there's just a disagreement?
So I think in all these situations where there's a conflict, and we define conflict as a gap between where you are and where you want to be, then we have to find a way of bridging the gap while letting go of an idea that someone's right and someone's wrong. So it's really about how do we move forward effectively. And I think that will really depend on the style or the personality or the ability of the house officer to communicate what's important in that scenario. And it may be a good place to start this patient's care is that I am responsible for the prescribing for this patient. This is my understanding of what I think would be the best in this scenario. And if you want to have a collaborative approach, ask the nurse, what are your thoughts on this? Is there a reason that you think that what I'm suggesting is wrong? In that case, perhaps I will escalate and ask my senior.
Yeah.
Because I think it is important to take on board the concerns of people who are more senior and more experienced. But at the end of the day, the bottom line does rest with the prescriber, and they have to do what they feel is the best for the patient based on their medical experience and the advice available to them, which may not just be at the remit of the nurse in this situation.
I think at the end of the day, you're right. The prescriber is the one who carries the responsibility. So if you go against your better judgment, allow yourself to be persuaded to prescribe what another person thinks is appropriate, and there's an adverse outcome, you're still the prescriber is the one who's going to be liable.
Yeah. And I think that's really fair, that when you say don't assume what the other person's response is, don't assume.
Yeah, that's good. That's a good tip.
Yeah, it's really good, isn't it? Because so often we go into an interaction thinking, oh, they're going to be really mad or they're going to be really hostile. And that makes us more defensive. And then you're less open and you communicate in a more defensive way.
Absolutely.
Yeah. Okay, so let's try another example. Let's say that your surgical consultant is rushing to theatre and they don't have time to consent the next patient for a laparoscopic procedure. And they ask that the team, our house surgeon, does the consent for the team. The house surgeon in this situation is in their second year. They're interested in surgical training, but never done this procedure. So, Sam, what do you reckon the risks are to the house surgeon here if they just go ahead and do this consent?
We know that just under 20% of HDC complaints relate to consent. And the process of consent is really important. And you don't know how important it is until something goes wrong. So it is a big responsibility. I do understand, though, the house officer might feel a little like they have to do it. The SMO's told them, the SMO's rushing to theatre, there's nobody else to do it. And if they want to get on a surgical training scheme, ultimately, there's pressure, isn't there, to take it on board and go ahead. But there is that risk of a complaint later. So you do need to think about that. If you don't know enough about the procedure to be able to do it, you don't have the information you need to provide to the patient so that they can make an informed consent. I think it's important you find out what that information is that is needed in that situation.
Yeah.
And whether that means trying to find, say, a registrar and say, hey, look, or whether you could talk to your SMO again. I think you need to consider your own safety. And it's also about patient safety, isn't it? Yeah. And, often patients do have questions. And if you don't have the answers, consent can't proceed.
Yeah.
So it will create delays, which might not be great for anybody. And so I think it's fraught, but you do have to consider the risks.
What do you think, Ashwina, if given this situation? You're in the moment, the house surgeon's in the moment, and they've just been asked. And they're thinking, I haven't done this before, but I should.
Yeah. So I can imagine it would be very stressful for a junior doctor interested in joining a surgical training scheme, because they would be torn between wanting to appear competent, but also knowing that they don't have the full knowledge or skills to explain this to a patient. Again, I think starting with openness is key. One approach might be to say to the surgeon, I'm unfamiliar with this procedure. Is there anyone else available to do the consent? I can observe and take consent for another patient once I understand the procedure. I can also see that in this situation, they may not feel comfortable to disclose that because that would feel vulnerable to them. And I think what Sam was saying is quite valuable. The onus of responsibility of the person taking the consent is that they do or are familiar with the procedure. And so another option might be that they start the conversation with the patient. They establish a rapport. They explain that there's some delay in the operating surgeon to be able to take the consent. And start the conversation to explain what they do know and explain that somebody else will come along to take the formal consent slightly later. I think that patients do understand that we as doctors don't know everything. And the more experience you get, the more comfortable you are by saying, I don't know, but I can find out the answer for you.
I think that that's a really good bit of advice, that all of us have limits to our knowledge. And I mean, even SMOs, right? And
Absolutely.
And there's no shame in asking. But I guess, if you're a house officer, you've recently been through university where it's like you have to know everything and you get tested all the time. And I think it constantly feels like a test. But I think it's a really good principle to live by, is I've reached the limit, I need to go and find out more, and not to feel ashamed of that. As an SMO, and a house surgeon came and asked either of you to, look, I don't know how to do this, I need help, how would you respond to a house officer? What I'm asking is, are you going to say to them, I can't believe you don't know how to do that, I haven't got time, go sort it out yourself? Would you ever say that? Or would you take a helpful attitude?
Yeah, absolutely. It's a something that we talk about in the drama triangle, stepping into the role where someone says, oh, they take a victim role by saying, oh, I'm just going to ask a silly question. And what you're describing in someone saying, why don't you know how to do that? It's just somebody adopting a different role in the triangle, which is to take the persecutor role. I think a healthy approach to any doctor who says that they don't know is to validate that's okay if you don't know. And if I fit within my jurisdiction, for example, with my trainees, to teach them, then I will do that. If it's, for example, someone on a ward who doesn't know how to put a cannula in and I'm just passing by, I will encourage them to seek some help to be able to do what they are tasked to do in a safe way.
I assume that SMOs, because they're normal people, I think you guys are normal people, would that be true? Have all sorts of different personalities. And I'm sure there are some SMOs who perhaps are a little gruff, who perhaps aren't as helpful to their junior staff. But I would hope that most would be helpful to a house officer. Is that your observation? I'm just trying to reassure the house officers listening that actually you're not all scary. Most of you are not.
No, I think most of us are there to help. And if someone asked for help, we'd provide that support. Even if it's, if, for example, it's about something that I would have expected that they'd done before. If they're doing if they're working in anaesthetics as a house surgeon and they're doing consent, I'd say to them, this is part of anaesthetics training. We have to get informed consent from the patient to give them an anaesthetic. So why don't you write down on the consent form what risks you're going to discuss with the patient, and we'll review that to make sure that you cover everything with the patient. And I think that's something that you could consider for consenting, even in specialties that you're not familiar with. To start, you could put down the risks that you're going to discuss, get someone senior who's done the procedure, who's informed about it, to review it first so that you don't miss anything. And then the patient can ask questions. I think
good.
Definitely we're definitely there to help.
That's really good to hear.
Yeah.
Ashwini, can I just ask, you mentioned this drama triangle. Can you just unpack that a little bit? It sounds fascinating.
Yeah, okay. So the drama triangle is a really elegant model of describing conflict situations and how drama unravels in the moment. It was devised by a psychiatrist, Dr. Stephen Cartman, about 50 years ago. So if you can imagine an equilateral triangle resting on its point, which demonstrates the inherent instability of drama. And then on each of the points is depicted a different role that we take in drama interactions. And each of the points are connected by bidirectional arrows. So on the apex, at the bottom is the victim role. And then on the other 2 points are the rescuer role and the persecutor role. So if you can and imagine the victim role. The victim role believes that they are the problem. They're not enough. They're the one that's making mistakes. In the rescuer role, they're the one that jumps in to fix things or take responsibility for others. And in the persecutor role, they're the one who criticizes, blames, or controls. And in medicine, we see this dynamic all the time. It's very common between patients, between teams under pressure, and between colleagues. And when I discovered this in 2019, I was fascinated. For weeks, I was going around just observing. And I think what makes the drama triangle very powerful is that people often switch between the roles without realizing it. And so what can start off as a simple miscommunication can very quickly escalate into something that feels a lot more overwhelming.
So I'm thinking that the victim, each of those roles are not necessarily helpful. Is that what I'm hearing?
Yeah, they're all drama roles.
They're all drama roles. So how do you pull yourself out of that drama triangle into what would be an appropriate way to handle a conflict?
I believe there are a lot of different tools and communication strategies that one can use. I think the first step starts with understanding the triangle, seeing that once we see that it's there and we see what role we're playing, we have the opportunity to step out. The difficulty when we're in drama is that we reinforce our position and keep justifying the position, digging deeper into the drama. And we feel that drama feels draining. We call stepping into the drama triangle, we call that as like an energy vampire. It sucks the energy out of you. And the tool I train, Compassionate Accountability, uses the compassion cycle, which consists of 3 easily trainable skills: openness, resourcefulness, and persistence, that helps us to harness the energy contained in the drama and move it around with compassion.
Sounds like that's something that all of us would benefit from learning about. It's fascinating. I must go do some research into that. Thank you.
Yeah, so Ashwina is going to talk a little bit more about that when we talk about conflict.
Oh, excellent.
Yeah.
In another podcast?
In the podcast that we're going to do about conflict and communication.
Okay, so for our listeners, who I presume are house officers, because this is part of our house office series, this another podcast with Ashwina will go on our general podcast. So if you're looking for it, that's where it'll pop up. It's on the MPS website. And you just Google MPS NZ podcast, it'll be there, or you can find us on Spotify and Apple.
Yeah. I'd be quite interested, Ashwina, in another situation where, the really difficult conversations that we are sometimes house surgeons are asked to do are like, for example, breaking bad news to a family. And that's such a difficult conversation that requires so much skill. But often in a busy team, that task is delegated to a house surgeon. And I can think that many times when I was a house surgeon, being asked to go give some terrible news or a blood test result that has significant implications for a patient, and thinking, I just don't know how to say this to the family, and I feel like this is I'm really out of my depth. Do you have some suggestions for us?
Yeah, I hear what you're saying, Cheyenne. In my anesthetic training in the UK, we did actually spend quite a lot of time in the intensive care. And I observed a lot of very, very skilled communicators, breaking bad news, discussing diagnoses with patients, end-of-life care. And so I've learned a lot just by observation. And I would encourage anyone, if they have the opportunity to do that, to spend some time observing more senior people. I think if you are in that situation, if I'm in that situation, one thing that helps me before I even start that is just to ground myself. So just take some time, about 10 minutes, just to get myself into the headspace of feeling calm and connected just to myself.
Yeah.
And breaking bad news is very difficult, primarily because, we are at that human interface between life and death.
Mm.
And having those conversations, firstly, we have to be comfortable having the conversation ourselves.
Yeah.
And realize that having that conversation with someone else does have an emotional impact on us.
Mm.
So the first thing I would do is take some time just to ground myself. And then I think, be open with the patients. You can voice that you find that this is a very difficult situation. What patients really remember is how they felt in your care and how you communicated with them. And that often has much longer impact than whether you said the perfect thing.
I totally agree with you, because if you go into it thinking about all the 15 other things that you've got to get through before the end of the day, and how this is really hard for you and how you just don't have time, then that will definitely come across.
Absolutely. And I think if you were in that situation where you'd rushed in and you'd been asked to do something at short notice and you felt, okay, I've spent a little bit of time, and then you leave with the feeling, oh, that didn't go well. I haven't really put my self across. I imagine that they're feeling even worse now. Then it would be okay to go back and say, look, I know this is a difficult time for you. I apologize. I was distracted with other work and couldn't give you my full attention. And if I came across as uncaring, this wasn't what I intended. And
Yes.
I'm deeply sorry for what you've experienced.
Yeah, absolutely. I think that's so important to realize that it's not that you just have one chance. You can definitely go back and talk to the patients and their family, and they appreciate that someone's noticed that they weren't fully engaged at the time, and that how important this conversation is for them, and to go back.
I think as doctors, and probably particularly when you're junior doctor, we are focused on the clinical, and because it's a learning environment, and it's a pretty steep learning curve early on in medicine, and you can be fully focused on that, and then it just becomes the dealing with the whole person can become a little more in the background. But practicing empathy, I think, goes a huge way in terms of building a rapport and reassuring patients. And the empathy is really around, I understand this is really distressing news, and I can see that you're upset, or I can see that you're angry, or, identifying, I can see what you're feeling. And people feel very heard when you haven't just heard the fact of what they're saying, but actually you see them as a person.
Absolutely. I think also what you're saying, Shan, is that when we communicate, it's also more than the words that we use. It's the tones, the gestures, the postures, the facial expressions. And having those difficult conversations, if we can find some time, turn off our phone, sit down with the patients, just spend some time there, that will have a big weight for them, that just to feel that someone cares. And really what they want to know, that there is a point of call for them to ask some questions if they want to know anything else, to feel that they're supported, to feel that they are, cared for in some way.
Yeah, so, and that goes for any time where you feel like an interaction hasn't gone so well. You can go back and say, explain, I'm sorry, I did not provide you with, like what you said before, Ashwina, that was really good. I was not fully engaged, and I didn't mean to come across rushed.
Yeah, there's no harm in admitting. And, a lot of us, because we feel defensive, because I think a lot of us are perfectionists, but it's hard to admit that we didn't quite get it right. But in our jurisdiction, in the New Zealand medico-legal environment, if you've done something wrong, the best approach is to front foot it however small that is, just admit it. Oh, I'm sorry, I got that wrong for this reason, and I'm going to do something about that now. I'm going to fix it. And that always goes so much better when you do that than if you withdraw, which honestly most of us probably want to withdraw a lot of the time because we don't like hard conversations, or whether we become defensive and no, I didn't make a mistake. So it's great for house surgeons to be able to begin to practice those skills.
Yeah, I think one of the things that I've read is that it's the difference here is I made a mistake. That just because I've made a mistake, it doesn't make me a bad person. I can feel guilt for making a mistake, but I don't need to feel ashamed.
Because the reality is we all make mistakes, all of us.
Absolutely.
Talking about making mistakes, and things get left out all the time on busy ward rounds. So we're going to talk now about, let's say that you've done this busy ward round and the consultant asked the registrar to check in with the infectious diseases team for a particular patient that's had fever and then start some antibiotics depending on what they recommend. And then the day passes and on the next ward round, the patient's still febrile and the consultant sees that they haven't been started on an antibiotic. And they say, well, what's happened here? And the registrar says, oh, well, the house surgeon, they were meant to call the ID and start an antibiotic, and they didn't do it. So in our work, we do see a lot of issues with ward rounds and documentation and plans that don't get carried out. Medications that are meant to be prescribed that don't get prescribed. Sam, have you come across cases where there's been a complaint or a bad outcome?
Yeah, there was an HDC case not that long ago, actually, where on a ward round the SMO clearly recalls asking for antibiotics to be prescribed for a patient. And the house surgeon is the scribe, as per normal, in a ward round, and documented the entire plan, but didn't document that part about the antibiotics. So there was a delay in patient receiving antibiotics, and there was a severe outcome as a result. And in an HDC case, what happens is that they scrutinise all of the care provided. And in this particular case, it came down to the SMO's account of what they recalled of that ward round, but SMOs don't document. That's what house officers do. And the house officer made very clear notes, but just omitted that. So it came down to credibility, actually, as to who had said what. But as a house officer, you can imagine, I mean, you're the bottom of the hierarchy. And so when someone's trying to shift blame onto you, I imagine you'd be stuck in this awful position of not knowing how to respond to that. So what are your thoughts on that, Ashwina?
Oh, I can imagine that would feel very tough. Internally, there would be different emotions to the ones that would necessarily be expressed externally. But again, starting with openness with the team and the patient, I made some notes. I guess they could say something like, I understand that a job on the task list was not completed yesterday. What's the best way to rectify it so the patient does receive the appropriate treatment, and how do we ensure that the error isn't repeated going forward? I think with these scenarios, the goal is to focus or shift the focus towards the patient care and away from blaming each other.
When it comes to adverse outcomes, it is common practice for us to try to cover ourselves and try and divert attention elsewhere. I think it's just human nature. And we see it a lot in complaints where we have multiple members involved who perhaps have a conflict of interest. And the difficulty is how you unpick that to work out actually where does responsibility lie. But when the HDC look at it, that's exactly what they're going to do. The more we try and divert attention, sometimes that just increases scrutiny. Doesn't tend to work that well.
And in those situations, sometimes what happens is that because of the discomfort and the blame shifting, the patient kind of gets a bit lost. So I think this strategy of depersonalising it and then bringing the focus back on the patient, what do we need to achieve? And let's focus on that and try and prevent this from happening again.
I think not in front of the patient, obviously, but if the house officer rang me and said, what should I do? I would advise them, one, to document so that they've kind of got all their words right and the facts straight in terms of what they think. Document what they recall of what happened. And so it's not about saying the registrar is lying. You would never do that. What you would say is, my recall of the situation was this. You know, that the SMO had asked the registrar and this was what was agreed. And that is my recall. Perhaps it might have varied from what I recall, but that is my recall. So you're not saying I'm right, you're wrong. You're just saying I'm presenting the facts as I understand them to be. And it's not a motive. It's not an accusation. It's simply stating the facts. And if you state the facts, they will speak for themselves. I mean, you say that to members all the time. Let the facts speak for themselves. Do you think that would help in this situation that you've talked about?
Yeah, I was going to see what you thought, because you'd be saying, my recall is that the registrar was going to do this. However, what I will do is call the infectious diseases team and just state it as a neutral statement, rather than saying, you were meant to do it, and now you're saying that I was meant to do it.
Well, I think the dynamic between the house surgeon and the registrar is probably separate to the dynamic of the error to the patient, and then separate again to how we're going to move forward with this. And they probably all need to be dealt with separately. I think it's important in this case to say something to the patient, and that could sound like, I'm afraid that your result yesterday was not followed up, and I want to apologise on behalf of the team. And as a result, we will change over your antibiotics, which will help you to get better. And we'll look at our processes to see that this doesn't happen again. What do you think about that, Sam or Cheyenne, in terms of how you'd close the loop with the patients in this scenario? Would that make an impact on what happens subsequently if there was a HDC investigation?
I think it's important that whatever you say to the patient must be accurate, because that will come out if there's a complaint. And so it needs to be truthful and accurate, but to the patient, they're worried about their care. And so, of course, open disclosure to the patient, we're sorry you were meant to have this antibiotic change yesterday. Unfortunately, it wasn't done, and we're very sorry about that, but this is what I'm going to do. And if they ask you, how did that happen? You can say, well, there was a miscommunication, because clearly there was, and that's truthful. But I certainly wouldn't say anything that might not be absolutely right, if that makes sense. So I wouldn't overtalk. I would just provide simple answers to the patient. And if they want to understand more and you're not sure what to say, look, we're still discussing about how this happened. And once we've, sorted that out and I've spoken to this person and that person, I'll get back to you with an explanation, so that you've left the patient with, I'm going to get my answers, I'm just not going to get them now, and they're going to come back. And that gives you time to get it right. Yeah.
And I think before the conversation, you need to work with your team to check that that's what they want you to communicate.
Yes.
Yeah.
You don't want to say something where the registrar and SMO immediately come back and say, no, that's not true.
That's right.
That would be not a good thing to do. But generally speaking, where there's a complaint, I found that SMOs are very protective of house officers.
Yeah.
That in an HDC complaint, it's not that common for house officers to have to provide a response unless they're directly involved in the care, as in you're the one who prescribed that medication. But generally speaking, SMOs are very protective, which I think is fantastic.
Yeah. And so there's another scenario that happens quite a lot, and that's if you're a house surgeon on a team with 2 different consultants, or you're working in ED and there's lots of different consultants, and you get different advice. So one consultant tells you to do X and the other consultant tells you to do Y. And they're quite different approaches to management. Have you got any suggestions, either of you, for how to approach this?
If you're talking about 2 SMOs within the same department or same specialty, you do need clarification. I don't think it's a case of, well, I don't know, you might feel different, Ashwina, but my sense is it's not about eeny, meeny, miny, mo. I would clarify with the SMOs to say, and look, using that word clarify is such a good phrase. Can I just clarify with you? You've asked me to do this and Dr. X asked me to do something different and I'm a little uncertain what I should do. So would you mind just being able to help me with this? Can we talk about this? And so that you can get agreement, hopefully, between the SMOs, or somebody needs to take the lead, right, and take responsibility for a patient. Ashwina, what do you think?
Yeah, I agree with that. I think that's really nice because it does show openness in I'm unsure. Can you clarify? Is perfect, open and resourceful. And I think what I might add to that is for the house officer to understand at that moment what is the most important part of the patient's care right now. And so, and how does what we're doing, how do these steps lead to that? And because it's important for anything that we do or anything a house surgeon does that they understand the reason. Why are they doing what they're doing? Are there different ways of doing that? I think we all know that as we evolve in our practice, there are things that we prefer to do because in our hand over time that those things have worked. But a pediatric anaesthetist told me a long time ago when I was a senior registrar that people will try to convince you that there's one best way to do everything, but in truth, it probably isn't the case. Perhaps for some things that's true. But for most things, there may be different ways to do them. And I think it's important to keep an open mind that that's the case.
Ashwini, can I just ask you a slightly different scenario where a house officer's been given an instruction by their SMO or registrar, anybody in seniority, and the house officer knows or has a strong sense that that's the wrong thing to do? Where do they go with that? What would you suggest that they do?
So if they think that the thing is wrong because it may jeopardize the patient's safety,
yes,
and that then they would have to speak out
to the SMO.
I suppose it would be contextual, and if it's time critical, that would be a very different situation to if it's something that may have an impact sometime later. But it's unlikely. Are you asking if the registrar asks the SMO to do something, so the house officer to do something that the house officer believes is not in the patient's best interests?
Yes. Or even if it's an SMO asks the house officer, there's a massive power difference there, obviously. So yeah, what would you do what would you advise the house officers to do in terms of, would you say to them, speak to the SMO, or would you say, is there somebody else you could go to? What would your advice be?
I think in truth, that power imbalance would be very difficult to navigate in the situation of somebody asking someone more junior to do something they felt to be unsafe. If they felt able to say, look, I'm unsure about this, can you explain the rationale? And they still insisted on them doing it, then probably the safest thing to do would be to approach someone out of the senior role and explain the situation, really to have a mentor or have someone to advocate for them, advocate for the patient. Really, this isn't about who's right. It's about doing the right thing and the safest thing for the patient. And in that situation, it would be very difficult for a house officer to override the wishes of a senior medical officer, I feel.
I think, especially like you say, if it's an emergency and they're wanting to do something that you don't feel is correct, and let's say they're asking you to act as an emergency, they're not on site, so they've given you advice. I think in that situation, you follow the process. So you talk to your acute on-call registrar and ask them for advice, and explain, I'm not sure about this management. I haven't done it before, or I haven't looked after a patient like this before. I've been advised this. You're the on-call registrar. Please, can you help? And then they can escalate, or they can act, depending on what the situation is. But you're right, that power imbalance is really, really difficult. And I've been in a situation before where I've been asked to do something that I really disagreed with by an SMO. And I think at that time, I felt really, really stuck. And it was in the moment they were supervising me and they wanted me to do something right there and then. And so I paused and stopped and just looked at them. And in the end, they did what they wanted me to do that I disagreed with. So I think in some cases there's no right response.
Right or wrong. Yeah, I think in the emergent situation, if you followed the instruction of an SMO, even though you thought that's not the right thing to do, because this is a time critical issue, if there was an adverse outcome, the SMOs instructed you to do it, so they carry the responsibility. It probably still doesn't feel that good because patient harm has happened, but the reality is, from a liability perspective, the SMO is the one that takes responsibility.
Yeah, especially if their name is on, they're the named consultant looking after the patient.
I think most of the time, if not all of the time, we are all in it to do the best that we can for the patient.
Yeah.
And as a house officer, you may not know what are the best things to do. They just may not be within your realm of knowledge or experience. And so there needs to be some trust there that the senior people do know what they're doing and that they are going to do the best for the patients.
Yeah. All right. So I think we had one more scenario to talk about, and I think this one's quite useful. So let's say that you're a trainee intern or a first-year house surgeon, and the registrar and the team's been uncomfortably close and making physical contact that you're somewhat uncomfortable with, and then they invite you to do an examination practice, and in front of the patient they touch you uncomfortably. What can you do? What would you do? Any suggestions? I'd say that if you're not feeling safe, that you stop and say, I don't feel safe, or you leave the room. So remove yourself from the situation straight away.
I think, initially you'd probably feel confused. Oh, is this legitimate? Is this what happens? Is this normal? But feeling like, I feel uncomfortable, I don't feel good about this, but I'm not sure I can say you need to stop. Ashwina, what advice would you give to house officers if they're in any situation where you feel like a senior doctor is starting to, encroach on your personal space in a way that you're finding uncomfortable? How would you advise them to communicate with that senior doctor?
Well, either verbally, I'm uncomfortable with the something simple like, I'm uncomfortable with how place that you're standing with me. Would you mind giving me a little bit more space? May not be that comfortable to say that. They could consider emailing that to the person, because I don't feel that this is a safe or professional way for me to work. That could be a first option. Again, we're talking about a power imbalance. If that sort of behavior is occurring, it's possible that those dynamics or those behaviors are also being observed by other people on the team. They could speak to somebody else on the team if they felt that was more comfortable for them, or one of the nursing members of staff, who may be someone that they feel would be supportive. Other than that, they could speak to a mentor or a supervisor. And I suppose if they really didn't feel that the person was hearing or listening to them, that the behaviour continued, that I would hope that hospital systems would encourage or empower them to be able to change the team in which they're working. Separate to that is what would happen outside, speaking to MPS and the ongoing follow-up of that. But the primary issue here is to get the house officer into a position where they feel safe to go to work.
Yeah, that's right. So you talk to your service manager and your HR personnel, and then from there talking to a trusted colleague, and then considering if you need to change teams. So all of that is down the line, but it requires the person to talk to your service manager and get yourself safe, because that's the first priority. Yeah. Okay, so this brings us to the end of our case discussions. Anyone have any final comments?
I think if I've heard anything today, it is that if you're in a junior role, you still have agency. You can still say no. You can still look after yourself. And it's about doing it in an appropriate way. Yeah.
And I really do believe that communication is just like every other skill in medicine. It gets better with practice. And you don't have to get every conversation perfect. The goal is to stay open, respectful, and willing to learn.
Yeah, that's so great. And I think, of course, it's natural when you don't have a lot of experience in a certain area to feel like, oh, you should already know how to do something. But like you've both mentioned, we're ultimately here for the patient. There's always room to ask for advice so that you can provide care for your patient. Don't forget the team around you. They're there to help you. So thank you, Sam, for joining me in this discussion, and a special thank you to Ashwina, who has provided us with such practical advice in approaching difficult situations. So many of our challenges are about communication. We really appreciate your expertise. Ashwina will be joining us in our wellbeing series as well. So thank you for coming today. Thank you to our listeners. I hope you've found this useful. If you enjoy our podcasts, please subscribe and like them. If you have any suggestions for other podcasts or helpful feedback, please email us at nzpodcasts@medicalprotection.org.